Okay, let's start with it. So I request all of you to be kindly mute yourself, and I will be very happy to take the queries in the end. And any queries you can post in the chat section, and there is a lot of polling questions, so I hope to respond when you get the polling option. And all the materials, including the slide set and the recording, will be provided. And again, please excuse for any inadvertent error. And thank you all for joining the webinar, and I hope this webinar will be useful for everyone. So let's get started with the rational management of Staphylococcus aureus infections. So today I'll be discussing about methicillin sensitive Staphylococcus aureus infection specifically. I'm opening the polling now. So I request all of you to answer. So Staphylococcus aureus obviously is a gram-positive cocci and in clusters. So these are specific for your Staphylococcus aureus. Next question, suspected sepsis. Cultures grew MSSA. What should be done next? So this is part of the webinar. So I'll be answering all these questions. And what is the treatment of MSSA? And whether the MSSA and MRSA treatment is the same or different. So again, we'll be discussing in the further part of this webinar. So just a brief introduction. It's a Staphylococcus aureus is a gram-positive cocci usually seen in clusters and which easily grows on your blood agar, giving the typical characteristic hemolytic colony. And Staphylococcus aureus when you're thinking. So these are coagulase positive. Coagulase positive, and another group is your coagulase negative Staphylococcus, which constitutes another group of infections which I will not be covering in my webinar. So coming to the diseases caused by Staphylococci. Diseases caused by Staphylococci. This disease by Staphylococci can be due to the direct invasion or even due to the exotoxin production. So the clinical presentation, as we all know, is varied. It can cause, it's the most common cause of skin and soft tissue infection, which can include your simple boils to complicated cellulitis and surgical site infection and skin and soft tissue infection. And the severe form, including your necrotizing fasciitis. And other infections which are caused by Staphylococcus aureus, it can affect your respiratory system in terms of pneumonia, especially it's seen in post-influenza state, bacteremia, endocarditis, meningitis, and it's one of the most common cause of. I request all of you to mute yourself.
கண்டிப்பா வந்துரும். நேத்தே ஒரு 15 hours தூங்கி இருப்பேன் நினைக்கிறேன். நேத்துல இருந்து இன்னைக்கு காலைல வரைக்கும். பாடி பெயின்ல இருந்துச்சு, டயர்ட்னஸ்.
So it can cause other infections like visceral abscess, and the toxin mediated infections include your staphylococci toxic shock syndrome and your diarrheal disease mediated by your enterotoxin. And staphylococci neonatal infection is also one specific entity which includes your bacteremia, meningitis, and your pneumonia. So one important entity common to all of this. So all of these infections can further lead on to your Staphylococcus aureus bacteremia. Again, this bacteremia can be catheter related. Primary, that is without any other source of infection. Secondary, Staphylococcus aureus bacteremia, that is secondary to your other sources of infection which I have already mentioned, and your complicated Staphylococcus aureus bacteremia. What is complicated Staphylococcus bacteremia? Again, we'll be discussing in further course of this webinar. So first we have this case. A 57-year-old man presents to hospital emergency with 3-day fever history and 12-hour history of painful swollen right ankle. On examination, he is febrile and his BP is 85/50. And his right ankle is red, swollen, warm, and tender. And there are no other potential foci of infection which is evident clinically. So the initial blood test showed he had thrombocytopenia with raised TLs. raise the LFT, that is transaminitis. Its CRP was 360. So what will be your provisional diagnosis when a patient is coming in this scenario? So again, I'll be starting this poll. I request all of you to respond to it. So yes, most of you have got it correct. So this is a case of septic arthritis with sepsis. So septic arthritis, as we all know, the patient had red swollen ankle joint, and also why sepsis? Because the patient's you can see the patient was in hypotension and he had features suggestive of other knots. So what would you like to do next? So this is a multiple choice and question. So you can choose every option which applies to you, to this case. What would you do? Oh, yes, most of you have got it correct. Like you have to do the USC guided aspiration and send it for gram culture, gram staining and culture, as well as blood culture is very important because the patient is in sepsis. Then what antibiotic cover you would need to give. So again, the antibiotic cover you need to give depends upon the source of infection. Here, this is a case of septic arthritis, where more commonly it is your GPC. So you'll have to give your GPC cover, do the USC guided aspiration and blood culture. Again, this is one, if there are no other potential source of infection which is noted, so just GPC cover will be sufficient. Next. So you made a provisional diagnosis of septic arthritis with sepsis, and you did a USG guided aspirate, which revealed it to be frank pus, and you have sent for gram staining and culture. So urgent gram staining showed gram-positive cocci in clusters, and blood cultures were also sent, and within 8 hours, 2 bottles were sent, and both of them grew. Both of them flagged at 8 hours, showing gram-positive cocci in clusters. So now what would you like to do? So launching the next poll. So most of you, majority of you have chosen vancomycin, some of you cloxacillin, and very few of you have chosen vancomycin plus cloxacillin. So here, so when a patient is when you want to start an empiric treatment and there is a clue that it is definitely going to be Staphylococcus, so it is better you give a combination of a vancomycin with your beta-lactam. Let's discuss in the next slide. So empirical therapy. So empirically, it is suggested that you start with vancomycin with an anti-staphylococcal penicillin. That is, it could be a cloxacillin, flucloxacillin, nafcillin, oxacillin, etc. And this treatment you can give up to 48 hours. And if the laboratory can't differentiate between whether it's MRSA and MSSA within 48 hours, there is required, you need to choose an alternative combination. It could be vancomycin plus your first generation cephalosporin like cephazoline, or daptomycin plus anti-staphylococcal penicillin. Why? Because there we'll be discussing there's one trial, camera trial, and in the patients having positive blood culture, mostly you will be targeting your MSSA, and if your local prevalence of MRSA is more than 25% in cases of patients who are not in sepsis, or if the patient is in sepsis, if the more than 10% is there, you will need to cover your MRSA as well. So why is this so? There is a camera trial which has showed that this combination of vancomycin plus flucloxacillin is nephrotoxic, and this nephrotoxicity will become evident after 3 to 5 days of treatment. And in case you start with vancomycin plus first generation cephalosporin, there was no associated nephrotoxicity. And why there is a difference, why which situation you will be choosing an anti-staphylococcal penicillin or cephazoline, again I'll be discussing in later part of this webinar. So after the next day you got this report. It's showing this is the report you have received, and so what will you be suspecting with this report? So what do you have to look at in the report or in the EST report? First, you will be looking at the cefoxitin screen agar, screen test. So if it is negative, what does it indicate? It is your methicillin sensitive Staphylococcus aureus. This is a case of MSSA infection. And one more clue is your oxacillin, both that is sensitive. It is a strain of MSSA and not MRSA. So this cefoxitin or oxacillin can be used as a surrogate marker. So your labs will not be reporting it as sensitive to others, like the drugs like sensitive to cloxacillin, flucloxacillin, cephazoline, etc. The sensitivity to these drugs will be derived or from the sensitivity to cefoxitin. So if it is reported as cefoxitin sensitive, it is sensitive to all of your beta-lactams like cloxacillin, methicillin, nafcillin, your BLBLI, oral and parenteral cephalosporins, and your carbapenems. And suppose your lab is not reporting cefoxitin sensitivity, but it is just reporting as MSSA. MSSA indicates that the cefoxitin screen is negative, so you can consider it as sensitive to all these antibiotics. So getting back to the patient underwent prompt arthrotomy and irrigation of the ankle joint. Hemodynamically, he is currently stable, but he is having fever. He is still febrile even after day 7 of adequate treatment. His transthoracic echo was done on day 4, which reported no valvular abnormalities and no other metastatic foci of infection was clinically evident. And his blood cultures remained persistently positive for MSSA. On day 1, day 3, and day 5, repeat blood cultures were sent, and these were all positive for your MSSA. So what would you like to do next? Most of you have suggested look for another site of infection. Next, others, and most of them others have split between other options. So this is a case of persistent bacteremia, and as I mentioned before also, there was no other site of infection which is evident by the patient's symptom. So what would you like to do next? So basically, you will have to first and foremost, in any case of persistent bacteremia, what you need to look for is first is ensure whether your source control is adequate. So for that, you need to do your repeat USG and see if there is any other any leftover collection of this abscess. Collection is there or not. Then next thing will be to do a transesophageal echocardiogram. As I mentioned before, TTE or transthoracic was negative. And next thing is host factor optimization. That is, if the patient is diabetic or is having malnutrition, you need to optimize these factors so that the antibiotic you're giving is adequately working. So before you escalate the antibiotic, all these factors to be considered, especially in a case of Staphylococcus aureus bacteremia. So this is a flow. So whenever there's a patient is having the Staphylococcus aureus bacteremia, first and foremost is look for the your thorough history as well as physical examination. If the focus is there, you do the rapid source control. So the rapid source control measure you have undertaken here. What is it? You have taken you have removed the pus, but still the patient is having. So next thing is you'll have to look for any other risk factor like IV drug abuser or hemodialysis or any other source of infection you will be looking for. Then if there is no source of infection and still the patient is having persistent Staphylococcus aureus bacteremia, you will have to do the transesophageal echocardiography along with followed by sending the appropriate cultures. So controlling the source is very, very important. So controlling the source in this case I have discussed is the adequate removal of the pus. Now the patients may have the catheters in place. So in that situation, you will have to ensure that it is removed because this any prosthetic material which is there will increase the likelihood of SAB relapse and hence should be removed even though there is not clearly infected. And there is a study which has showed that there is an 18-fold increase in Staphylococcus aureus BSI relapse if this prosthetic device is not removed. And especially if the patient is having short-term catheter, it is necessary that it should be removed immediately. If it is a long-term catheter, if there is no other contraindication and the patient you can reinsert it. So you can state the first option will be to remove. If it can't be removed, you can use antibiotic lock therapy. Other prosthetic material like prosthetic valve or prosthetic joint, pacemaker, ICD, again the recommendation is you have to remove it as soon as possible. And if it is not medically possible, it is not possible to remove it, then you can consider addition of rifampicin, or the patient should be put on long-term suppression. So what is the role of echocardiogram in case of Staphylococcus aureus bacteremia? It has been studied that around 11 to 30% of the patients with SAB, that is Staphylococcus aureus bacteremia, will have endocarditis. Hence, it is very important you do the thorough history taking and examination for any patient. And echocardiogram should be done in all the patients who are having Staphylococcus aureus bacteremia. And in that also TEE is preferred over TTE because of increased sensitivity and ability to detect other complications like valve abscess and perforation. And T is the first test of choice if the patient is having any risk factors for endocarditis like prosthetic valve or pacemaker, or if the patient is having persistent bacteremia. And when should you plan this TEE? It is 3 to 5 days after the onset of bacteremia. So on the 3rd day or the 5th day of the persistent bacteremia, you can plan for TEE. Why? To minimize the risk of false negative results. And apart from this echocardiogram, what else you should do? So if a TE is negative, what else you will do? CT of the affected area to look again for the persistence of the infection, MRI of the spine, PET scan. And again, the choice of the investigation will depend upon the initial signs and symptoms of the patient. So again, so it's like which of these patients of Staphylococcus aureus bacteremia should undergo your TEE. This is so they have devised various prediction rules or various scoring systems which are used for ruling out endocarditis in patients having Staphylococcus aureus bacteremia. The first and foremost, the first score is your VIRSTA score for SAB. And basically, this scoring system will help you in predicting whether the patient should undergo echocardiography based on the risk of the infective endocarditis. So, any patient having the VIRSTA score of more than equal to 3 should undergo TEE if the patient is having all the features. So, that could be your patients having CNS or peripheral emboli, any meningitis. Like this is all I'm talking about Staphylococcus aureus meningitis. Then patients having CID or ICD or previous infective endocarditis, native valve disease, any IV drug abuses, persistent bacteremia, vertebral osteomyelitis, community acquired pneumonia. So community acquired pneumonia. So patient, how will you use this score? So now a patient is coming. So in this, consider the case we just discussed. The patient was in sepsis. So you will give a score of 1. And the patient is having persistent bacteremia, 3. So 3 plus 1 is 4. So this patient has to undergo TEE. Then now another patient. So the patient is a case of meningitis, they have ICD placement for meningitis, for hydrocephalus undergoes meningitis, or the patient who is admitted in the ward, he has developed meningitis, that is healthcare associated meningitis, then and the culture has grown Staphylococcus aureus. So again, in that case, you will have to do the TEE. So other scores. So again, they have studied that the TTP, what is TTP? Time to positivity, has an implication in patient, like indirectly predicting the risk of your infective endocarditis. So TTP of less than 9 hours again is associated with higher risk of infective endocarditis. Hence, you have to do the echocardiography to rule out. So this is a scoring system, that is your positive scoring system, which depends on your TTP. If it is less than 9 hours, 0.65. So a cutoff of this scoring system is 4. So apart from TTP, there is IV drug use, vascular phenomena, and predisposing heart disease. Another scoring system is the PREDICT scoring system. Again, this PREDICT scoring system, they do consecutively on day 3 and day 5. So the cutoff for day 5 score is 2. So the factors they have considered is ICD, permanent pacemaker, community acquisition of the infection, or whether it is a healthcare associated infection, positive culture after 72 hours. So these are the things they have considered. So again, which of the scoring system should I use? So they have evaluated all these scoring system in predicting the infective in the endocarditis in case of Staphylococcus aureus bacteremia, and they have seen that Virsta score has the highest negative predictive value. So basically, the scoring system, it's better if it has a very good sensitivity and high negative predictive value, so that you are unnecessarily avoiding the TE. So this so this scoring system you will be using. So if the in any patient who is having Staphylococcus associated bacteremia or Staphylococcus aureus bacteremia, you have to do this Virsta scoring, and then if this Virsta scoring is more than equal to 3, please subject the patient to TE. So next, one more important thing is you should document the clearance of this infection. So to document clearance, you have to send repeat blood culture every 48 hours to 72 hours. That is, every 3 to 5 days, you will have to repeat the blood cultures. So it is a very common practice that you just send one blood culture, and if it is positive, you will just treat based on that report. It is very necessary that you document the clearance, so that one, you decide the total duration of treatment, and to rule out the existence of this persistent bacteremia. And as I mentioned, persistent bacteremia is defined as positive blood culture after 3 days of appropriate antibiotics, and positive repeat blood culture is a predictor for metastatic infection or endocarditis. So if the patient is having persistent bacteremia, you will have to evaluate in depth for any other metastatic infection or endocarditis. So this is a typical one. So first on day 1, the blood sample was sent, and 24 hours, the first Staphylococcus aureus culture has come positive. Next, what you will have to do, you will have to look for the risk factors. So this is nothing but the Virsta scoring. So you will have to look for the various risk factors, and if the score is more than 3, perform TE. This is one of the way. Other, the patient is having persistent bacteremia. As I have shown, persistent bacteremia has a score of 3 by itself. So you can use, if the patient is having persistent bacteremia, that again you will have to do TE to rule out endocarditis. So again, one more common scenario is just one bottle. Most of the times they will send single bottle, and that single bottle grows Staphylococcus aureus. So what should you do in this condition? Again, they have done one study where they have seen that there is single positive blood culture bottle is also associated with around in a sizable risk of infective endocarditis and mortality, and hence it should not be neglected and should be thoroughly investigated. At least the minimum next immediate step should be sending repeat blood cultures, so that you are one thing, you are ruling out persistent bacteremia, and you are also proving this is an infection. So even a single bottle which is flagging Staphylococcus aureus or which is growing Staphylococcus aureus should prompt thorough investigation. So again, it has been seen that as soon as the patient is diagnosed to have Staphylococcus aureus bacteremia, it's better to consult an iris specialist. So so that again, as I mentioned, all the things are looked in the patient. So this brings us to the next question. What is the drug of choice for MSSA? The drug of choice for MSSA is your anti-Staphylococcus penicillins, and now there is increasing evidence. First generation cephalosporin like Cephazoline again is one of the, could be considered as one of the drug of choice. So why not vancomycin? This I have got many times. So when whenever a patient is all empirically started on vancomycin and then it grows MSSA, I have received many clinicians calling and asking like, why not continue this vancomycin? Again, there is lot of evidence. This is one of the comparative study which have evaluated the beta-lactam versus vancomycin in treatment of MSSA among 122 hospitals. And here again, the patients receiving beta-lactam had 35% lower mortality when compared to patient who received vancomycin. So 35% mortality is mortality benefit if you give beta-lactam, and extra mortality if you give vancomycin in treatment of your MSSA. Next, this is one more study which they have confirmed the outlook for the outcome of vancomycin treatment in patients with MSSA bacteremia. Again, the SAB related mortality in patients receiving vancomycin was significantly higher than beta-lactam therapy. And even the multivariate analysis proved that the odds ratio of having higher mortality is around 3.3. This is another study where they have evaluated the Penicillin or Cephazoline versus vancomycin in MSSA bacteremia. Again, the patients who are on anti-staphylococcal penicillin or the first generation cephalosporin had almost 80% lower mortality hazards when compared to patients who are receiving vancomycin alone. So empirically, you can give the combination of vancomycin as well as your anti-staphylococcal penicillin whenever you're suspecting a Staphylococcus aureus infection. But once a culture report comes and it is proven to be MSSA, if you're still continuing the patient on vancomycin, you are just increasing the higher chances of mortality in the patient. And again, the convenience. So one of the major issue of your anti-staphylococcal penicillin is it is 6 hourly, so 4 times dosing. So the convenience of this vancomycin dosing should not outweigh the potential benefit of your Penicillin or Cephazoline. So now coming to the treatment options for your MSSA. So first and foremost is your beta-lactam agent. So as we all know, beta-lactam exhibit time-dependent killing. That is the most important PK/PD parameter is time over MIC more than 40 to 50%. So this is achieved by giving prolonged infusion over 3 hours or by giving continuous infusion in patients having more severe or critically ill. So next, apart from beta-lactam inhibitor combinations also can be given. So again, which situation you will give BLBLI? As we all know, most of the isolates of Staphylococcus aureus are penicillin resistant more than 90%. So none of your amoxicillin, ticagrelor, or piperacillin alone are going to act. So addition of this beta-lactam inhibitor will inhibit this beta-lactamase and hence it will be functional. So, and as we all know, this BLBLI has a good anaerobic coverage as well gram positive and your gram negative coverage. Hence, these can be given as an empiric therapy in case you are suspecting mixed infection. Like your empirically, you can in patients having skin and soft tissue infection, you can give. If the patient is in sepsis and you don't know it, you can still just give your piperazine piptaz, so which will cover most of your like gram positive, gram negative as well as anaerobic. So these can be used as an empiric therapy. Next, the drug of choice is your anti-staphylococcal penicillin, so which includes your napcillin, cloxacillin, oxacillin, flucloxacillin, and dicloxacillin. Again, these there is not much difference between the pharmacokinetic profiles or the efficacy in between these, but there is seen that in dicloxacillin has lower potential to cause cholestatic hepatitis, but dicloxacillin again there is higher infusion associated phlebitis as well as interstitial nephritis. But these anti-staphylococcal penicillins are preferred over your first generation cephalosporin. Why? So the two most important factor is your first and foremost is your inoculum effect. So what is this inoculum effect? So as the concentration of the organism or the infection is high, so the ability of the first generation cephalosporin to act in that situation is lower. And this is due to the production of the higher production of beta-lactamase. So this we'll discuss when we discuss this first generation cephalosporin. So what is available in India is mostly cephazolin, or cephalosporin also can be used. Cephazoline is available, so I'm just going to concentrate on that. So what are the advantages of this first generation cephalosporin? The advantage of use is, first and foremost, is a low cost. When compared to your anti-cephalococcus penicillin, these are lower cost, has longer T-half, so you can give a so anti-cephalococcus penicillin, most of them will have 6 starly, that is you have to give QID dose, whereas your cephalosporin has a longer T-half, permitting your like BD dosing as well as dosing in the OPAT regimen. Next, it is known to be less nephro and hepatotoxic than your anti-cephalococcus penicillin. So these are the advantages. The major disadvantages or the major controversy regarding the first generation cephalosporin is your cephazolin inoculum effect. And this phenomena is mediated by the type A beta-lactamases, and this is seen where the infection or where in severe infections and where the infection concentration is of the bacteria is high. That is in case of infective endocarditis, osteomyelitis, septic arthritis, and in cases of your large abscess. And one more disadvantage of your first generation cephalosporin is it has a little broader spectrum of coverage, hence it is has higher chances of developing C. diff associated diarrhea, which is again minimal when compared to other generation cephalosporin. So these are the controversy, and this is the ongoing subject, or various trials are undergoing, which one to prefer over other. So one of them is optimal treatment of MSSA, a meta-analysis of cephazolin versus anti-cephalococcus penicillin. Here they have seen that there is, in the group receiving cephazolin, the 90-day all-cause mortality was lower, and one more disadvantage, is, as I have mentioned, the odds of discontinuation due to adverse effects like a nephrotoxicity was much lower in patients receiving cephazolin, and there was no difference in the clinical failure which was observed. And this is one more study where they have compared the cephazolin and your anti-cephalococcus penicillin. So here again, the infection recurrence rate was higher in patients having patients treated on cephazolin. So again, this is one more study where they have compared cephazolin with anti-cephalococcus penicillin. I mean, it's a systematic review. Though there is evidence of lower mortality and less nephrotoxicity, the various studies which have analyzed this are on infections which are usually having low concentration of low concentration of bacteremia, and most of these cases, or where the infective endocarditis, the number of patients were very low. Hence, you can't consider this as a blanket statement that cephazolin is better than anti-cephalococcus penicillin in all the cases of Staphylococcus aureus infection. Again, one more study, they have same finding. There was no difference between cephazolin and your anti-cephalococcus penicillin. So this brings us to the same question. So what should I use now? Again, as I mentioned, potential therapeutic inferiority of cephazolin versus anti-cephalococcus penicillin is always a concern, especially in patients who are having severe MSSA infection. And hence, like severe infections like endocarditis and deep-seated infection. And these cases are underrepresented in most of the studies which I have shown before. Hence, so where can you use cephazolin? So cephazolin can be used in uncomplicated MSSA bacteremia, and it can be used in consolidation or completion phase. So initially, you treat the patient with anti-cephalococcus penicillin, and once the bacterial burden has reduced, so that there won't be any inoculum effect. So after adequate source control, you can shift the patient on cephazolin. And in cases of severe infection and like endocarditis and deep-seated infections of CNS infections and pneumonia, it is better to be anti-cephalococcus penicillin should be given. So I hope I'm clear. So in severe infections or deep-seated infections, endocarditis, you will prefer anti-staphylococcal penicillin, that is your cloxacillin, flucloxacillin, etc., over cefazolin. And cefazolin can be used once in cases of uncomplicated bacteremia and once the bacterial burden or once the source control is achieved. So if there is a large abscess and you're able to drain out most of it, so you can still give cefazolin. Again, as I mentioned, this is an ongoing, the most of the studies or the systematic review, they have seen that most of the in conclusion were based on retrospective analysis, and there was no head-to-head comparison or randomized control trial. So this is one trial, placebo trial, where they are looking at efficacy of cloxacillin versus cefazolin in MSSA. This is an ongoing study, and they will primary inclusion will be completed in June 22, and there is one more trial, the SNAP trial, Staphylococcus aureus network. They are looking at various combinations. First is MSSA treatment, cloxacillin versus cefazolin. Next, they are looking at various in MRSA, the role of combination. Again, this trial has just started, so these trials will help us in further like refining our treatment for your Staphylococcus aureus infections. And next, what is the role of non-beta-lactam agents? So I have discussed all the beta-lactam agents till now. So what is the role of macrolides? Macrolides are inactive against your MRSA, so this can be taken into consideration in using in cases of only MSSA because they are active in around 85%. And again, these are bacteriostatic agents. So these are not recommended in severe infection or serious infections like your endocarditis. So where you would prefer a bactericidal agent. And erythromycin is not recommended as an empiric therapy in situations where because most of the places are erythromycin resistant. 15% of the strains are erythromycin resistant. Next, 4-trimoxazole. Again, this is one of the oral agents, so you can use it as a step-down therapy. And they are active both against your MSSA and MRSA. Next, the aminoglycosides. Again, these are agents which remain active against both your MSSA as well as MRSA. And the role of the amikacin or gentamicin, which will basically come in treatment of your Staphylococcus associated prosthetic valve endocarditis. Just remember, and like gentamicin has no role in native valve endocarditis, but this comes into picture in treatment of your prosthetic valve endocarditis. But in most other situations, this is not used. Next important group is your lincosamides, that is a clindamycin. This is a synthetic derivative of lincomycin. This again has a broad spectrum of antibacterial covering your GPC, GNB as well as your anaerobes, and it has one important advantage is again it is available in the oral formulation. And important thing is they are not active against your MRSA but active against MSSA. And again, being bacteriostatic, you will not be using in most of the severe infection. So where does clindamycin come into picture? One most important place where clindamycin is used is where you desire an anti-toxin effect. Like I have mentioned, the Staphylococcus infections, one of the, apart from direct invasion, your toxin-mediated effects. So wherever you want an anti-toxin effect, you can use your clindamycin. And they have good penetration into your bone and your abscesses. And hence it can be used in cases of MSSA osteomyelitis and septic arthritis. So summarizing, in uncomplicated bacteremia, your cefazolin can be used and then cloxacillin both can be used equally. And especially cefazolin again is preferred when there are penicillin allergies. And there is no role of combination with aminoglycosides or rifampicin in case of uncomplicated bacteremia. If it is complicated bacteremia, again, the same thing but you will be avoiding Cephazoline as much as possible, and until we have further good evidence. And role of combination therapy in case of MSSA, there is no clear evidence showing that combination should be given, but in case there is a failure of therapy, you can use cloxacillin or Cephazoline plus daptomycin or cloxacillin plus fosfomycin. Again, there are not much studies on this. Most of them will respond with monotherapy. There is no role of combination therapy. So this is one summary table which I have made. Again, I'll be trying to cover most of these infection, particularly in case when I am discussing in the next MRSA. So in case of MSSA, so the duration of treatment will remain same whether it is MSSA or MRSA. Further, MRSA may be complicated and it may require a little longer duration, but MSSA. So this is the duration of therapy. In case of simple abscess, just incision and drainage is sufficient and there is no requirement of an added antibiotic. If there is large abscess, you can give dicloxacillin, or second alternative could be clindamycin, and duration is for only 5 to 7 days. Complicated SSTI, the antibiotic of choice, like for in case of MSSA, is mostly the same, cloxacillin or nafcillin or Cephazoline. So Cephazoline, as I mentioned, will be preferred in uncomplicated bacteremia, and it will be used as an alternative therapy whenever there is your associated allergy or once adequate source control is achieved. So for uncomplicated bacteremia, you need to give only 2 weeks. Complicated bacteremia, you will be giving for 4 to 6 weeks. And it should be noted that for bacteremia, whenever the patient is having bacteremia, the entire duration of the treatment should be parenteral route, and there is no parenteral to oral shift. Again, these are subject to various studies which they are looking at cutting short or giving a shorter treatment as well as early shift to the oral. In case of endocarditis, flucloxacillin or cloxacillin can be used, and the treatment, important thing, 6 weeks after the culture is sterile. Again, yeah, important thing, even in bacteremia, it is 2 weeks after the culture is sterile. So if you have started the patient on treatment today, like today, and up to 5 days there was persistent bacteremia, and day 7 there was clearance or there was culture was sterile. From day 7 you have to give 2 weeks of your flucloxacillin or in the appropriate therapy. In case of bacteremia and endocarditis, this is the rule you have to follow after the culture is sterile. In case of pneumonia, especially in case of necrotizing pneumonia, clindamycin, flucloxacillin, cloxacillin will be the first choice. And in case of necrotizing pneumonia, clindamycin, as I mentioned, has an added advantage, and the duration is around 2 to 3 weeks. Osteomyelitis and septic arthritis, these are little difficult to treat infection. Again, in case of and both of them, adequate source control is very, very necessary. And in case of native osteomyelitis, the duration of treatment is 2 weeks of IV followed by 2 to 4 weeks of oral. And in case it is prosthetic joint associated osteomyelitis, if you can, it is better if you can remove or change the prosthesis. If it can't be removed, again the duration of therapy will be extensive as with the additional quinolone or rifampicin treatment for chronic suppression, chronic suppressive bacteria. And in case of septic arthritis, the duration of treatment is around 2 to 4 weeks. So again, these are the doses. This is one study where they are trying to compare the short course versus prolonged therapy. And in case of low risk MSSA infection, short courses also can be tried because they are associated with the similar mortality and clinical outcome. Again, this is subject to further studies. Until then, this is the whatever I mentioned is the duration of therapy should be followed, and it should be on treated on patient to patient basis. Next, so I have one more case. A previously healthy 18-year-old boy with no past medical history or significant trauma or travel suddenly presented with flu-like symptoms, vomiting and diarrhea, And obviously, first thing, COVID-19 is negative. He was treated as provisionally query viral pneumonia, query gastroenteritis, and he was treated symptomatically with antiemetic and analgesic. And next, 1 week later, he presented with fever, increasing pain, weakness, and inability to lift or move his left leg, the site where he had received the injection. And physical examination revealed tender, warm, erythematous swelling of left thigh, extending up to the upper thigh and hip joint. And the patient was having tachycardia, leukocytopenia, and transaminitis. Ultrasound was done of the left hip. Chest X-ray was taken. Echocardiography was done. Doppler was done, and there was no abnormality detected in any of these. And so the patient was provisionally diagnosed to have necrotizing fasciitis with septicemia, and blood cultures and pus samples were sent. The patient was given clindamycin, ceftriaxone, vancomycin, and croxycillin. The same day, the cellulitic area extended around the right, extended up to the right knee and increased rapidly. So a CT scan was done, which revealed collection abscess around the left hip, but not involving the capsule of the joint. And immediate exploratory laparotomy was done, and the abscess was drained. Post-op, he was transferred for ICU for post-op care. In the ICU, he developed persistent cough, which was productive, and there was bilateral crepitation in all the lung fields. Chest X-ray was taken, which was suggestive of ARDS with GGOs. So blood and pus both yielded the growth of the previous one, which was sent, yielded the growth of MRSA. So in this case, is there any other test you would like to perform? So what is this scenario, and why is this patient deteriorating suddenly? So initially he had flu-like symptoms. Then suddenly after 1 week, he developed necrotizing fasciitis, and now he has a picture of your ARDS. So what will you suspect in this case? And is there any specific test you would like to look for? Now this is a case of MRSA, which has grown in blood and pus. So actually, I forgot to add the polling option here. So in a situation like this, you'll always have to, apart from the MRSA, you'll have to look for one thing called look for the PVL toxin production. So PVL or Panton-Valentin leukocidin is an exotoxin which is produced in 2 to 5% of Staphylococcus aureus strain, and PVL it is usually seen expressed in higher concentration in MRSA up to 75 to 100%, and in MSSA in a lower percentage, 9 to 45%. Again, depends on the place. And what is the important thing I want to convey here is the presence of this PVL gene. The patient will have higher risk of more severe infections such as necrotizing pneumonia, osteomyelitis, septic arthritis, sepsis, and multi-organ failure. So it is very important that you have to have high suspicion and vigilant of this PVL positive Staphylococcus aureus infection so that you make the prompt diagnosis and start adequate treatment. So when will you suspect this? So it can be suspected in patients having sudden onset flu-like symptoms, then he is having continues to have necrotizing fasciitis and recurrent abscess, or in household cluster of infection. And usually the history will they will be having when the patient is presenting to you with severe musculoskeletal infection and then rapidly progressive pneumonia preceded usually by flu-like symptom, and the patient is presenting to you with fever, leukopenia, and increased inflammatory markers. So in this situation, you should be highly suspicious and you should look for this. And conventional bacterial cultures which you send will not differentiate PVL producing Staphylococcus aureus from others. And it is necessary that you do PVL toxin detection or toxin or the gene detection. And how will you do this? It is essentially by a PCR most of the places. And again, there are various then PVL toxin by ELISA is available, as well as there is currently, which is under study, and lateral flow assay, which can find out this PVL toxin, which is not currently available in India. And in patients, so whole body MRI or PET scan can be useful. So if you can't diagnose like PVL toxin, you can't detect now, at least you should have the suspicion in the mind, and you should subject the patient to the whole body MRI or PET scan, where you'll be seeing multiple abscess, necrotizing pneumonia. So in this case, you will have to add, so addition to the usual anti-staphylococcus regimen, again depending upon if it was MRSA or MSSA, you have to add an antitoxin agent, which could be clindamycin, rifampicin, linezolid, or gentamicin. So there is higher risk of mortality in this patient, as well as if the patient is not adequately diagnosed and treated. So what are my take-home messages from this? So even if, first and foremost is, even if a single bottle is flagging Staphylococcus aureus, you should never disregard it as a contaminant, and you should always look for a source. Echocardiography should be done in cases of all the patients with SAB, and T is the modality of choice if the TT is negative. And controlling the source is equally very, very important. That is removing your infected catheters and prosthetic devices, and evaluating for other metastatic foci of infection, and documenting the clearance. That is, you have to send repeat blood cultures every 48 to 72 hours to document the clearance. And if it is not, there is persistent bacteremia, you will have to look for the metastatic foci, or you should do look for infective endocarditis. And you have to treat with the right drug. So in cases of MSSA, if you're treating with vancomycin, is as good as treating the patient with no drug. So you should give the right drug at the right dose, and right duration of therapy is important. So these were my references. Thank you. So I can take the questions now. Any questions?
Yeah, Akshita, this is Dr. Sumit.
Hi, sir. Good evening, sir.
Yeah, good evening. Very well presented as usual. I just had a small query that most of the places that you've given the recommendations for treatment, you have written flucloxacillin
Yes, sir.
as a first choice, whereas for skin and soft tissue infection, you've written nafcillin as a first choice.
Yes, sir.
Is there any specific reason for that?
No, actually, all of the whichever is available, I don't think so. Nafcillin is currently available. So dicloxacillin I had mentioned, sir, for skin infection as far as hello.
And what I have explored in the market in chemist shops also, what they are have got is amoxicillin cloxacillin combination. Is there any role as a microbiologist or as an ID specialist that you would recommend amox clox anywhere?
No, sir, I have not come across this combination anywhere. And as I mentioned, MSSA doesn't require any combination of agents for treatment. So again, there are so many indigenous combinations which are available only in India. So yes, sir, I have not heard of this combination.
And like what I just saw in a presentation, the antitoxin effects among the four that you mentioned, I think clindamycin, gentamicin, linezolid, rifampicin.
Yes,
out
sir.
of these four, which one would have the maximum antitoxin effect?
So clindamycin is the first choice they have mentioned, sir, in most of the guidelines.
Right.
Yes, sir.
Right. Okay, thank you so much. And one more thing is that, what I have also come across is that whenever you're coming across any MRSA or any staph infection from any patient, you must always take the history of any past tubercular treatment, because invariably those staph aureus isolate, whether it's MSSA or MRSA, are almost always resistant to rifampicin.
Okay. Yes, sir. Yes, sir.
So when you go back, you check for rifampicin susceptibility, find resistant, you'll always find that that patient has been on anti-tubercular treatment.
Yes, sir. Yes, sir. Yes.
So I think with suspected staph infection, you should always take a history for any past tubercular infections.
Yes, sir. Yes, sir. Sure, sir. Yes, sir.
Thank you so much.
Yes, thank you, sir.
Thank you.
And one more thing I would like to mention is in case of bacteremia, rifampicin you will not be giving when if the patient is having active bacteremia. Again, one thing is to that is higher easily resistance can emerge. Again, I'll be discussing it in the MRSA subsequent webinar. Yeah. Any other questions? Okay, I'm just checking out the chats. I have already addressed any specific reason for not using Vanco and MSSA. I think I've already addressed. There are various studies which proves that this is associated with a higher mortality. Treatment of uncomplicated MSSA. Again, in case of UTI, most of the like whatever I could find out, there is no guidelines, especially for MSSA infection. So you can use the same treatment as like cloxacillin. Then yeah, if MSSA in initial cultures during the course, if one culture is growing MRSA, what should be the course? So yes, this is a very common scenario where initially the patient will be having MSSA. This is one evidence, like one thing in that patient, if you go back, the patient would have not received the appropriate agent for MSSA. So that could be one of the another thing is yeah, so that situation I think it's better to add treat vancomycin and add an MSSA agent as well. If it is subsequent culture, you can treat the MRSA. In some situations, we have already also found that pus is growing MSSA and blood culture is having MRSA. In this situation, what we have done is we added like Vanco plus your Cephazoline for treatment, or better to go for Daptomycin also in that situation. Then what is next question? If the source is catheter and we cannot remove it, what has to be done? As I mentioned, in case of prosthetic, so you can try for antibiotic lox solution, which can be used. Otherwise, if it's in case of catheter, if it is a prosthetic device which can't be removed, in that case, you will be going for quinolone with or without with rifampicin as a treatment. What else? Three-year-old with recurrent pustules in left underarm at an interval of 2 to 3 months. He has been treated with permethrin solution, lotion and hydrazine. There is temporary relief, but again presents with same condition. What could be the possible reason? So this is a 3-year-old child. Always first and foremost, you'll have to look for any existing immune deficiency, chronic granulomatous disease. Rule out that. Then one more thing, important thing is, apart from the antibiotic, you will have to advise the adequate care of the site. So that is one of the next reason for acquiring recurrent infection. So I think these two should be the most important. If empirical treatment start with ceftriaxone, later blood culture shows MSSA, what to continue? Again, this is one of the common scenario. So again, there are various studies which have been assessing the ceftriaxone in MSSA. Few studies have shown it to be non-inferior, but there are few studies which also shows that there is inferior outcome when the patient was treated with ceftriaxone. So if you can give, and again, these drugs are much cheaper. Cephazoline and your flucloxacillin are really cheap drugs. So if you can give a better drug and it is associated with lower mortality, then why not? what to do in MSSA if the patient is not responding to Cephazoline and Staphylococcus penicillin. As I mentioned, first and foremost, host optimization, source control. And if at all these two also are not affecting, then you have to look for any other source of infection. Then the role of combination is not, and repeat cultures. If there is no role of actually combination, if at all there is no response, you can then shift to the combination, whether, I mean, either, or you can upgrade to daptomycin. You can give it the combination of Vanco as well. And I think I have covered all the questions. I hope I have covered all the questions. Okay, so any other questions? Okay, if there are no questions, I would like to end this. Thank you all for joining this webinar. I hope it was useful, and I'm really sorry for the initial technical glitch which happened. So I hope all of you will fill the feedback form. And I'll be sharing this recording as well as the PPT. So the recording will be shared in my YouTube channel. Thank you.